Okay. As I said, I'm trying to see how I can see all your messages because I've not been seeing any. Okay. Okay. So I've made some changes. I hope that you people will be. I hope that I will be able to see your messages because previously I wasn't seeing any of your um, I wasn't seeing any of your messages. So please, can anyone try and send any message? Let me see if I can see. Can anyone try and send in any message? Let me see if I can see this time around because previously I could not see. Let's try and send messages. Let me see if I can see. I couldn't see. Not sure, but can you people see my own message?
No, we've not seen one here. But we have seen people that message within ourselves.
So, but but it's my message that you cannot see. So this is what you'll be doing for me, right? Because I think it is important for me to be seeing your messages. I try making changes while I be new number. So what will happen is more than one year to a message, just screenshot it and send it to me on WhatsApp.
Okay, sir.
Okay, please let us go on. I think from now I've found a way. I've gotten help on how I'll be seeing your messages so that I will be responding because it's only fair to you that I respond to the message. That's why. Okay, so now I found a way of getting your messages, because it's extremely important that I get your responses, because if I'm not getting your response, it will be of no benefit. So if you have any question, you can ask, and I believe I should be able to respond to you. Okay. So let us go on, please. It's like I'm the only one seeing my messages. I'll work on that on our subsequent courses. Okay, so the principles of management of HHS is similar to DKA. However, there are some differences. Okay, so there are some differences between HHS and DKA, but the principle is the same: fluid therapy, resuscitation, fluid therapy, insulin therapy, correction of electrolyte imbalance, prophylactic against thrombosis, and treatment of the precipitant. So it's similar, but you will see certain differences. Know very well that in DKA, the cardinal treatment is insulin, because it's seen in type 1 diabetic or type 2 diabetic that has no insulin. So in DKA, the cardinal treatment is insulin. I'm not saying the other principles of management are not important, they are, but in DKA, the cardinal treatment is insulin. But in HHS, the cardinal treatment is fluid therapy. Okay, so for the resuscitation, for those who were here, we discussed resuscitation. You talk about the airway, the breathing, the circulation, and I said yesterday that when you're talking about the circulation, it's extremely important that you calculate the shock index, right? So for the fluid therapy here, as I earlier said, the fluid deficit in HHS is almost 9 to 12 liters. So what you observe as a house officer, as a resident, is that by the time you give the patient 2 liters, it is possible that you see a very sharp drop in the blood sugar. Right? If you have experienced this one, please write it in the comment section. Sometimes if you personally, I've experienced cases where a patient comes with 20 something. By the time you give him the initial 1 liter start 1 liter in 1 hour, you see that the blood sugar will just come down to 10 and sometimes to 9. That's why I said that the cardinal treatment in HHS is fluid therapy. Because if you make the mistake of rushing to give insulin without giving fluid in this kind of patient, by the time you give the fluid, the patient will have hypoglycemia. Because this is a type 2 diabetic patient and he doesn't need much insulin. What he needs is fluid therapy. So you can see the deficit is a lot. And that's why sometimes patients will complain to you that when I was admitted, I was given almost 1,000 fluid, right? It's because of the amount of fluid that we give HHS patients, right? So very important. Don't make the mistake, ever make the mistake of giving HHS patients insulin before fluid. You are going to be in a lot of trouble because the patient will likely develop hypoglycemia. So always make sure that you give fluid first. Okay. So the next thing is insulin. This is also extremely important for those who we lost during our last session. Please kindly join. We are back again. Kindly join. Just click on the live session and you will be there. Okay, so for those who are for insulin, it's extremely important for you to know that you give half of what you give DKA patient. So if you are giving a DKA patient 0.1 international unit per kg per hour, in HHS you give 0.05. As I earlier said, these are people that still have residual insulin, so they don't need a lot of insulin. Because I know that the mistake that most house officers make is by giving everybody the same, whether it's HHS or DK, you are giving 6 international unit hourly. You will notice, and if you have experienced this, please write it in the comment section, that once you say that as I gave the first dose, the whole blood sugar crashed, right? So if you have experienced it, please write in the comment section. You see that if you give the patient maybe 6 or 10, you see that the blood glucose will crash from 30 to maybe 6, 7. Why? Because the main problem is not insulin deficiency, right? So, but you give 0.05 international unit per kg, and you check hourly. You need a drop of 3 to 5, as I discussed yesterday. If it's less than 3, you add 2. If it is more than 5, you reduce 2. And when it's less than 14, you change to subcutaneous insulin, as I explained yesterday. But when you are changing to subcutaneous insulin, the only difference is that the daily requirement of insulin in patients with type 2 diabetes is 0.3 to 0.5 international unit per kg. For those who attended yesterday's meeting, I said if it is type 1, it is if it is type 1, okay, if it is type 1, it is 0.5 to 1 international unit per kg. But if it is type 2, is 0.3 to 0.5 international unit per kg. Let me give you an example. If the patient has maybe is weighing, let's say 60 kilogram, I like using 60 all the time. So if the patient is measuring 60 kilogram and you are using 0.3, that is what? That should be 18. So you are going to give the patient 6 international unit TDS, isn't it? So that's what you do. You can see that the dose you use for patient with HHS is lower. Okay, so very important. And I can see that there are people that say they have experienced this problem. Okay, so it is, don't rush to give high dose of insulin. Hello? Sanufa, muke lafiya. Okay, sorry da Allah, ina wani zoom meeting ne, bari zan kira ka. All right, so if you have experienced it, this is a wake-up call, right? This is a wake-up call. Make sure you don't make that mistake again, right? Don't make that mistake again of giving the patient high dose of insulin. Okay, all right, okay. So the next thing is correction of hypernatremia. We discuss it. You give 0.45 saline, and the correction of potassium, we discuss it. If it's less than 3.3, you commence correction of the potassium, but don't commence insulin. And if it is 3.3 to 3.5, you give 30. 3.5 to 40, you give 20. And 4 to 4.5, you give 10. And if it's more than 5.5, you don't give any potassium correction. We discussed this one yesterday. Okay, so but one of the most important thing in HHS that you must know is you must give prophylaxis against thrombosis. You must give it. If you make the mistake of not giving prophylaxis against thrombosis, you come and see the patient the next day having stroke, having pulmonary embolism. If you make that, and that patient will not forgive you, because the patient will think that is your treatment that gave him stroke, or is your treatment that gave him pulmonary embolism. And some cases, the patients will believe that you are the one that killed their patient. You cannot miss it. If you know Vicos triad of hypercoagulability, stasis, and endothelial injury, you know that a patient with diabetes has both endothelial injury, and patient with HHS has hypercoagulable state. So you give low molecular weight heparin 40 international unit daily as prophylaxis. You cannot miss this. As a doctor, you cannot miss this. If you miss this, get scared. See, let me tell you something, right? One thing that you should know as doctors is that, first of all, do no harm. If you fail to write Lexine for a patient with HHS, you have done harm. You have done harm. And if you are in my unit in endocrine, me and you will have serious problem. Because we have seen several cases that you have managed patient, the sugar is better, a patient maybe stood up to maybe go and ease himself, and all of a sudden the patient will just collapse and die. Or because of pulmonary embolism, or the patient will develop stroke. So you cannot miss prophylaxis against thrombosis. Extremely important. Okay, so other factors, you treat the precipitant. If the patient is on insulin, you teach the patient insulin. You counsel the patient on compliance on medication. You treat infection with broad spectrum antibiotics, and while you are waiting other culture, you do percutaneous coronary intervention if it's myocardial infarction, or you give thrombolysis. Just treat whatsoever is the precipitant of the HHS, right? Make sure you treat it. So we talked about conversion to premise insulin. But for patient with HHS that is type 2 DM, if the blood sugar is good, I prefer changing it to premise insulin. But you can as well change the patient back to his oral medication, keep the patient for a day or two, then subsequently discharge the patient. But for those who are in my unit, you observe that I like changing it to insulin, discharge the patient on insulin. When they come back to the clinic, then we can change them back to their oral. But you can change the patient back to oral while the patient is in the ward. Keep him a day or two, then you discharge. So indication for discharge: the blood sugar must be normal, they have normal osmolarity, the individual must be well hydrated, and the precipitant should be well treated. There shouldn't be any residue or any problem. Okay, so I'm happy today that most of you came here on time. So this HHS and DK, they are just like twins. So the discussion is similar, but I've pointed out some of the differences. So if you have questions, please ask questions. Let's discuss. Please, if you want to ask questions, ask practical questions. Thank you. I'm waiting to see your questions. Okay, okay, so if we have questions, please let's ask. Let's ask questions so that we get clarification. HHS. Please let's ask questions. I've given some time for anyone to ask questions. If you have questions, please say it. I need to answer it. So it is, you see, the major difference is if you treat HHS as DKA, you end up having hypoglycemia. Because, and if you make the mistake of giving the patient high dose of insulin, let's say 10 international unit, you come and check and find your patient is hypoglycemia. And at that point in time, you start correcting hypoglycemia, right? So it is very important that you know the difference. And the only way you know the difference is you doing your analysis, you calculating osmolarity, you determine checking if the you checking if there are ketones or no ketones, right? Because if you do that, you'll be able to differentiate if it is HHS or it is DKA. All right. So if there are no questions, please, that will be the end of today's discussion. Tomorrow we'll start 8 to 9. We'll be discussing hypoglycemia. So if there are no questions and you understood the discussion on HHS today, please write understood, thank you sir, so that we'll conclude today's discussion. So you can type understood, thank you sir, so that I'll be sure you understood your question, and let us conclude for today. All right. Never forget, for those who are on call today, don't forget thrombolysis. If you have not picked anything from this discussion today, please remember thrombolytic therapy, prophylaxis against thrombosis, because of the risk of stroke and hypercoagulability, stroke and acute pulmonary embolism. Please do not forget. Okay, so Dr. Mutala asks of hydration in heart failure. This is very, very important. Dr. Mutala, is a very good question. And for the new house officers and even the old ones, if you have any patient that is in failure, right, first of all, what you need to determine is that individual, is that patient with heart failure, right, in shock, or is he dehydrated? Once you establish that patient is dehydrated, correct the dehydration only. And most of the time, correcting dehydration, if you give heart failure patient 1 liter slowly in 2 hours, that will correct the dehydration. So after correcting the dehydration, no need for maintenance. The patient can just take daily requirement of fluid orally. That is practical. But ideally, you are supposed to do cardiac catheterization and measure the pressures in the heart. So you'll be giving the fluid and measuring the pressures in the heart. Once it's getting high and the patient is at risk of pulmonary embolism, you reduce or stop the fluid. But we do not have the facility for cardiac catheterization and measurement of pressures in the heart and the chambers of the heart, right? So we can't do that. The only thing you can do is make sure the patient is not dehydrated. If he's dehydrated, give him 1 liter slowly, let's say over 1 to 2 hours. After that, no need for maintenance. You commence your insulin therapy, right? The patient can be taking fluid orally. So that's how we maneuver that. Hope I have answered your question, Dr. Bello Katakum. So the issue of 9 to 12 liters, it doesn't come to play again if the patient is having heart failure. The issue of 6 to 12 liters doesn't 9 to 12 liters doesn't come to play again, because there is that issue is very, very important. Okay, hope I've answered your question, Lola Katago. And if does anybody have any other question? So this same applies to patients with CKD. If an individual have CKD, it's the same thing. If patient has CKD and you see that the patient is bloated, don't give him a lot of fluid. Instead of doing good, you will likely be doing harm. Okay, so any other person with any other question, please, if you have any question. Tomorrow we are going to leave hyperglycemic emergency. So tomorrow it will be hypoglycemia. And for my new fresh doctors, you remember we talk about hypoglycemia, the way to treat it. And I'm happy that Isa Yusuf, during your dinner night, he talked about it. You people are the latest generation. You cannot just be doing 50 meals or 50% in double dilution, right? Because that one is hectic, is difficult, and cannot help anyone, isn't it? So any other question? Does anyone have any other question or has any clarification? Okay. If there are no any questions, please document that. Thank you, sir. So that we'll conclude. But if anybody has it, please let him answer. If there are any other questions, please ask. Okay. So I've not seen any new question. So it is safe to say we can call it a day. So tomorrow is 8 to 9 a.m. Please, let's start on time so that you can have time for your weekend. Thank you all for joining. I hope. No, it's not p.m. It's a.m. Please, 8 to 9 a.m. It's weekend, so I'm careful not to interfere with people's lives. So 8 to 9, before you begin your weekend, we'll just quickly finalize this So we'll be discussing on hypoglycemia. So if you have practical questions on hypoglycemia, please bring it, right? Okay. So have enjoy the rest of your day. Take care of yourself. Bye bye.